Well, hello, everyone. Thank you for making it today. I know it's Friday. Maybe it's been a rough week for everyone working, And well, today we're going to go over this webinar about the venous insufficiency. So we're going to go over the anatomy first, some physiology, and then after this, we're going to talk about how the exam is done, and it will be fun. All right. And then at the end, if you guys have any questions, let's do this. So I have today with me Darian. So we're gonna do this together. We're gonna make it dynamic, where we're gonna have fun, and let's do this. Let's begin. All right. So let me go to my presentation here, and there we go. So here we have this. Okay. As I said before, the title of our webinar today is Introduction to Venous Insufficiency Exams. And this is something that, with this of the vascular labs increasing in our nation, so we have more type of these exams. So patients are under interventions all the time. They use the radiologists, they use this catheters to go inside the saphenous vein and fix all these problems. This is a big deal nowadays. So my name is Alain Fernandez. As I said before, Darren is going to be with us today, and we're going to share this presentation. And our sponsor is RGS Healthcare. So for any needs that you have for medical equipment or anything, this company is like always right there for you to help you. So like my system, I bought it from here, and I'm going to show you my system today. I'm just going to use it, and I'm going to do ultrasound with it, and you'll see how the quality is. All right, so let's begin with some anatomy. All right, I'm just going to go over the anatomy of the deep system. All right, because remember, we have for the veins, we have a deep system and we have a superficial system. For the arterial system, we only have a deep one, right? So, but for the venous system, we have a superficial and a deep one. So let's begin right here. So we have the inferior vena cava right here, and then draining into the inferior vena cava, we have the common iliac vein, which is this one right here. And let me use the laser. I think it's gonna be better if I use the laser, so you guys are gonna see it better. Okay, so right here. So we have the inferior vena cava right here. Okay, so this one common iliac vein, which is gonna drain right into here. Okay, so we have the internal iliac vein, and then we have the external iliac vein right here. So at this point, we have the inguinal canal, and then above the inguinal canal, we have, the external iliac, but just right after or below the inguinal canal, we're going to have the common femoral vein, right? Now, the common femoral vein, draining into the common femoral vein, we have the deep femoral vein, or profunda, that's another name, that means deep, right? And then we have the femoral vein. Some people still call it the superficial femoral vein. But because it's kind of confusing, because remember, we have a superficial venous system and we have a deep one, most of the people out there prefer to call it just the femoral vein. So not to confuse everyone and say, well, this is like old name superficial femoral vein, but just in case you see it, it's the same of the femoral vein. And remember that when we do the protocol for the DIP system, and the reason why I'm talking about this substance, because as Darian is going to talk later, we have to do the protocol for the DIP system first, and then after this, we're going to do the protocol for the superficial system. So the way we go is like, hey, we do a proximal, all right? Then we do mid, and then we do, distal, all right? So remember, this vein is just going to run through one anatomic structure that we call the Hunter's canal, which is made of muscle. And the exit is just going to be right here. And we call this the adductor hiatus. That's basically where these, the femoral nerve, the femoral artery and the femoral vein, they're just going to go through. That's why we have a tendon right there. That's why this area right here, when you're doing the compressions, it's just sometimes very hard to compress. and it's painful for the patient. And also, let me tell you something. It's a commonplace for DVT formation after the soleal sinuses. So you have to know that the most common place for DVT formation is the soleal sinuses, but the risk for thromboembolism is not going to be so high as if it was in here at the distal femoral vein. All right, then once the femoral vein exits the Hunter's canal through the adductor hiatus, so we're going to have the popliteal vein, all right? It's just this one right here. So draining into the popliteal vein, we have the tibio-peroneal trunk, which is this one right here. And then we have the two, let me tell you something, even though in this picture we have only one vein, we have two of them, all right? We have one anterior tibial artery, and then we have two anterior tibial veins, okay? So two anterior tibial veins draining into the popliteal vein, right? We have two peroneal, and we have two posterior tibial veins. So take a look at the deep anatomy, so that's good to know, all right? Because it's like I said before, you're just gonna have to do the protocol before going into the superficial system. And the reason is because maybe Darian's going to talk about this later, but remember something, patients, they may have primary varicose vein or secondary varicose veins. And most of the times when there is secondary, the problem could be in the deep system. So that's why you have to check if the problem is right here. Okay, so moving forward, let me show you this veins in here. So sometimes you're scanning the calf muscles, all right? And then you see all this like dark holes everywhere and you say, hey, what's going on in here? And those are what we call the calf veins. They're so deep. Sometimes they are dilated, all right? And we have the gastrocnemic or gastrocnemius muscular or pseudo veins. And let me tell you something. Let's take a look at this one right here, gastrocnemius right here. So you need to know that they drain into the popliteal vein, right? So this one's right here. So gastroc right here, all right? That's the popliteal fossa, all right? So this one is the small saphenous vein right here. This one belongs to the superficial system. All right, so this is the gastrocnemic right here. And also we have right here the soleal sinuses. And like the name says, those are sinuses. So they're basically a type of a reservoir for the blood down there. So they don't have any valves. Let me tell you this, all right? They don't have any valves. So that's why they tend to have blood stasis and they tend to dilate and they tend to form thrombosis over time. But this, the soleal sinuses, you're just gonna empty or drain into the peroneal veins, all right? So let me go here. So here I have one soleal sinus. So it's draining into this peroneal veins. Or like, for example, this one right here, soleal sinus is just draining into the posterior tibial vein. So take a look at this one, soleal sinus, right? So here we have, as I said before, remember, we have two posterior tibial veins. We have two peroneal veins in here. So that's a nice picture. So usually you get this picture when you're scanning at the level of the calf muscle. So they're deep soleal sinuses. Okay, moving forward, let's talk about the superficial venous system. And for the superficial venous system, we have the great saphenous vein and we have the small saphenous vein. So let's take a look at this picture here. Okay. And the reason why the name is superficial before going into the anatomy is because they are like over the muscular fascia. They're so superficial. In fact, you can see it in some patients, you know, all these varicose veins, which are basically being fed from the either the small saphenous vein or the great saphenous vein in here. So look at here. So that will be the beginning, okay, at the dorsum of your foot right here. And then it's just going to run medially, okay? And let me tell you something, is the longest vein in your body. It has approximately 12 to 20 valves in total, all right? And it's just going to drain into the common femoral vein. Remember, it belongs to the deep system. So here will be the connection, one of the connections from the superficial system to the deep system, because we have more connections. And those connections, we call them the perforators. Well, we're going to talk about those perforators in a little bit, right? So here, this is the great saphenous vein. Take a look at this. It's so long, all right? It runs through your medial aspect of the leg. And here we have this small one, all right? It's very short. It starts at the lateral aspect of your foot right here. And then it goes and drains into the popliteal vein. All right, so let's go back to this picture here. Let me show you something. Here, this is the popliteal fossa. It's the popliteal fossa area. And this is the small saphenous vein, so you're gonna find it there. So meaning that if you keep scanning up, you're not gonna see this one, right? Okay, so this one runs more medially. The great saphenous, the small saphenous is gonna run more laterally, all right? So let's keep going in here. And let me show you this. When you're scanning the saphenous vein, all right, the great saphenous vein, so most of the protocol, we're just gonna do it in here. We also check the small saphenous vein. So Darren is gonna go more in details about the protocol and the pictures that we take and all of this. But sometimes, you know, we see all this accessory saphenous vein in here, and they're out of the saphenous fascia, or fascia, which is this one right here. So saphenous fascia, that's how we call it, right? And here we have what we call the muscular fascia right here, this one. So the saphenous vein goes together with the saphenous nerve in here. Now, it's good to know this picture, and I'm going to show you this with the machine right now, because sometimes we get confused with this accessory saphenous vein that many patients are going to have, and then we think that that's the main saphenous vein. So I'm just going to show you what it looks like when you're scanning, so you get familiar with this. Maybe you do this every day, but sometimes like it's hard to see it in some patients, let me tell you. Sometimes they're so small. Sometimes the anatomy is a little bit crazy. Sometimes the patient has a previous ablation and the saphenous vein is interrupted, and then you see something like this, and you think is the main saphenous vein, and it is not. So I'm just going to show you this anatomy real quick, and with the machine, so you have an idea of how this one looks like. All right, so Darian, let me know if everything is just going clear, if my voice is perfect, or let me.
You're good.
Yeah, good, perfect. Yeah,
Yeah.
because I don't see the screen in here. I'm just like on the computer. All right, good. Let me go here and let me know if you can see the machine right in there. Let me just go here. A quick capture of the system. Okay. Well, we have to give it a little break to the technology. Okay, let me just go here. Okay, it seems like my the other webcam is making a conflict with the one that I'm using for Zoom. But anyways, I'm just gonna show this system, right? I'm just gonna go here. Okay. scanning myself here. All right, mine is very good, but in some patients you're going to see it's so huge. Let me just like place the focal point in the perfect position right here. All right, and let's take a look at this anatomy. Okay, so this one, all right, this one is the skin right here, all right, and this one is the subcutaneous tissue right here, all of this. So this one is the saphenous fascia, this one right here. Okay, this is my great saphenous vein right here. And this is the muscular fascia right here, okay? So the great saphenous vein is just gonna be between those two fascias all the time, between this one and this one. The reason I'm telling you this is because sometimes you're gonna find those accessory veins like outside of the fascia, and those are not the great saphenous vein. So that's good to know. So this is the way it looks like. So it looks very nice on this system. All right, very good. Let me see if I can get it in sagittal. Okay, so I had it right there. My left is like, doesn't work very well. Okay, I don't have a reflux, I think. See how sensitive the color is right here. Okay, so there is just going to explain how we do this protocol right here. But the flow here is very, very, very slow, all right? So doing this type of insufficiency exam sometimes is a lot, challenging for many people, all right? So let's keep going with the presentation. Okay, so remember what I said before, the great saphenous vein, it's just gonna drain into the common femoral, which is this one right here, okay? And here we have the superficial epigastric vein. So the flow is just gonna come this way, right? And this vein is just gonna drain into the, Saphenofemoral junction. That's how we call this section in here. So just imagine that your patient, for example, has one thrombus here. What's going to happen is, like, of course, the flow that is just trying to go into the common femoral vein is just going to go retrograde, all right? And the flow that is just coming through the superficial epigastric vein is just going to go retrograde as well. So that's something that is going to tell you there is a problem right here. And also, if you have reflux, all right, so flow is just going to come this way, all right, and it's just going to go this way too. So that's good to know when you're doing the this picture is part of the protocol. So you take a look all the time to the saphenofemoral junction, and that's the way it looks like in sagittal, and this is the way it looks like in transverse. We call this the Mickey Mouse sign. So we have one of the ears in here for the great saphenous vein. So common femoral vein in here. We have the femoral artery, which should be the common femoral artery. So that's a beautiful, nice picture. So at this time we do like, when we have this picture, we do a compression. So we got to make sure that this great saphenous vein and the common femoral vein both go away from the picture. All right. So also we have what we call the communicating veins. They belong to the superficial system as well. All right. So let's say, for example, we have this one. We call this one the posterior arch or posterior accessory saphenous vein, this one right here. And it's like, it belongs to the superficial system, like I said before. So it connects the same great saphenous vein in 2 points. So distal and proximal. And also take a look at this perforators in here. So there will be perforators connecting the posterior tibial veins to this posterior arch veins in here, this one right here, and perforators connecting the great saphenous vein to those posterior tibial veins that they belong to the deep system, like I said before. So that's one, all right? And then we have this other one in here, we call the vein of Giacomini. So this one runs in the posterior thigh, right, this way. And it connects the small saphenous vein to the great saphenous vein. So small saphenous vein right here goes this way to the great saphenous vein. So this vein tends to be insufficient most of the times. Maybe you've seen this on many patients before. It's a huge, large vein and it's painful. And sometimes, you know, doctors, they want to ablate it and close it. So to avoid like this sensation of heaviness and pain in the posterior thigh. All right, so those are what we call the communicating veins. And here, those are the, here we have the perforators, all right? So remember, perforators are going to communicate, they're going to communicate the superficial system to the deep system this way. So remember, the flow is just going to go all the time, all right? I mean, if the patient is fine, if there's not a problem, it's just going to go from the superficial system to the deep one. Now, if, for example, you see the flow going in a different direction, think about like maybe there's a stasis in the dip system, like the dip system says, hey, I have more room for flow in here. Or maybe there's a high pressure. Sometimes the problem is not even in the veins. So maybe the patient may have, let's say, pulmonary hypertension, the right side of the heart is affected. So the superficial, the dip system cannot drain very well into the right atrium of the heart. And that will increase the pressure into the dip system. So that pressure is going to be released into the superficial system. Or let's say, for example, how about if the patient has 1 DVT in here? So the flow cannot go up. It's just going to release, the pressure is just going to be released into the superficial system as well. And the perforators, you know, flow is just going to change in that direction from the dip system to the superficial one. And of course, these perforators are going to become insufficient. All right. So moving forward in here, those are the different type of perforators that we have. We have the Cockett perforators. They are close to the ankle right here. Then below the knee, we have the Boyd's perforators in here. Above the knee, we have the Dutz perforators. And then, you know, in the high thigh area, we have the Hunterian ones. A nice way to remember, even though it doesn't have to do anything with this, I remember all the time like CBD, like I said before, you know, that belongs to the abdomen, the common bile duct. But that's a nice way for me, like saying, hey, I don't remember like the names because sometimes they're hard to remember. I go like CBD, and that gives me an idea of which are the perforators, you know, and how they are located. Okay. All right. So let's talk a little bit about physiology real quick in here. And that was a question that I always had it for me. Like when I was a kid, before going to school, I was like, hey, how is that possible that the flow can go from my legs to my heart? So against the gravity, how is that possible? And, you know, when we go to school, we learn that it's like a teamwork. So we have those calf muscles like working the entire day, like a squeezing and sending the flow up, squeezing all the time. All right, this is like a second heart. In fact, we call this the peripheral heart. It's just like just working the entire day, even though when you're not doing exercises, they have what we call muscle tone, and they're like contracting all the time. So that's why when you don't help these muscles, you feel the pain at the end of the day. And, that's why it's good to, like, when we finish this webinar today, you go and take a little break, watch a movie on Netflix or whatever. And then you put your legs resting, in favor of the gravity. So that helps with the return to the heart. Well, the calf muscles, they make their work. But if we don't have these valves, all right, it's like nothing, because they're just going to allow for unidirectional flow towards the heart all the time. That's why when the patient develops, insufficiency, so it's going to have reflux, all these ulcers, venous ulcers are going to form over time because of stasis. There will be change in the coloration of the legs, so it will be crazy. So, and one of the complications for DVT is basically, valve insufficiency. It happens all the time. All right, so respiration is the next one. I'm just going to leave the respiration for the end. But, the heart also works, has this suction activity. When it is in diastole, it creates like a vacuum into the venous system, and it makes the suction of the flow, helps the flow coming back to the right atrium through the superior vena cava and through the inferior vena cava. And, the respiration, it helps with something that we have in the veins that we call physicity, which is basically this up and down like sea waves all the time, right? And let me tell you something, it doesn't happen in all the veins, right? So veins, as they're closer to the heart, they're not going to have this physicity. They're going to have more like pulsatility. But for the peripheral veins, they have the physicity, like something like this, right here. So it goes like up and down, right? Have a spontaneous flow and physicity, all right? So you know that they have augmentation with distal compression, and they have augmentation with proximal release as well. But look at the respiration in here. Respiration has two phases. So inspiration, when you're like, taking the air, right? So what happens in here is that the diaphragm is just going to move downwards, right? That will increase the intra-abdominal pressure. The thoracic one is just going to decrease. So that will make the flow, that is coming from the legs to decrease, and the one that is coming from the arms, the neck and the head is going to increase. All right, so the flow through the inferior vena cava is going to decrease. The flow through the superior vena cava is going to increase. So if you know inspiration, of course, you know expiration. Okay, so during expiration, now the diaphragm is just going to move towards the thoracic cavity, right? So the intra-abdominal pressure is going to decrease. The intrathoracic one is going to increase, and not just the other way around. The flow coming from the legs or through the IVC is just going to increase, all right? And the one coming from the arms, the neck, and the head is going to decrease. So like I said before, the inspiration and the expiration, they're going to create this phasic, that's how we call it, phasic flow in the veins, like something like this right here. So right now I have my sample volume right here in the femoral vein, and I see this physicity, this up and down, right? And I know that this part is when the flow is decreasing. So maybe at this time the patient is in, it makes sense, in inspiration, because the flow, the venous return is decreasing, and this one is in expiration, all right? So it makes sense, inspiration in here, expiration in here. Okay, also something that we do, many times is the Valsalva maneuver. And basically the way it works is, you tell the patient to breathe in a real deep, like, hey, okay, breathe in, right? And then push, right? So when that happens, the abdominal pressure and the thoracic pressure both are going to increase. So that will make the flow in the whole venous system to stop. If you see like reflux at that time, or like, I mean, if you see one augmentation at that time, it's because the valves are not working. There's a problem in there because the flow should stop everywhere. Now, if you have like, you know, let's say for example, this right here, let me show you. So let's say, okay, let me connect my tablet. Okay, so let's see, you're doing your veins, and then this happens, tells the patient, hey, can you like breathe in and push? So this is what's going to happen, right? The flow is just going to stop. And then he tells the patient, hey, can you release? So if you have like something like this, all right, that's normal. Sometimes just a little bit of reflux is fine, right? But if you have something like this, and then you have something like this, of course, there's a problem right there. Okay, there is a huge reflux, there is a long reflux, there is venous insufficiency. So Valsalva is just going to help you. It helps a lot. All right, let me come back to the presentation here. And well, that's the time for Darian. All right, let me just like close my screen and then you start sharing yours.
Okay.
Take your time. Let me just close mine.
All right. Okay. So, hi everyone. My name is Darian. I'm from Sonography 101. So first off, we're going to start by covering the patient position. You're either going to have the patient in reverse Trendelenburg, so like that, or standing. Some facilities prefer the patient to be standing. Others don't really have a preference, or they actually do both. I've seen in some facilities that they do the reverse Trendelenburg first, and then they still do the patient standing as well. Okay, so after you decide as far as like which position your facility prefers, you're going to go ahead and start the protocol. You're going to start with your usual DVT protocol. This will vary from facility to facility. So just again, make sure that you're aware of what images you're supposed to take. You're going to start the common fem right up here. Then you're going to go into the Saphenofemoral junction, femoral vein, proximate distal. Like Elaine mentioned before, you want to make sure that you're calling it the femoral vein rather than the superficial femoral vein. That way there aren't any confusion when they get the results and they don't know whether it's a superficial vein or the actual deep vein. So then you're gonna get the popliteal vein, posterior tibial veins, perineal vein, and gastrocnemius veins. You can actually evaluate the gastrocnemius veins when you're in the pop, like Elaine showed you guys. So when you're in the pop, you can evaluate a few things: gastrocnemius and small saphenous veins. So even if you're not doing a DVT study, when you're in that pop, you can evaluate a few things and make sure that the issue is not with any of those other vessels, okay? So even if you don't image it, just, take a look and see if you can learn on how to take those images for the future, okay? So this is what it would pretty much look like. Your compressions first, then go into grayscale, color Doppler, pulse wave Doppler, okay? And do your augmentations and all that as you're going through each segment. I know some people do their compressions and grayscale and color and so on and so forth, but if you're able to, do your compressions first, make sure that there's nothing there, then that's definitely the preference. So this is the image that I was telling you about. Here you have your popliteal artery popliteal vein, and gastrocnemius vessels. The veins, the artery, veins, artery, and then here's the small saphenous vein. So you can evaluate a few things when you're in the popliteal fossa. Look for a Baker cyst, you know, whatever the case may be with that patient. And then back over here, we have the PTVs and the perineals, and then the soleal sinuses as well. So those are really great images, you know, to be able to learn what it looks like an unusual patient. And then if something is wrong, then you already know what's going on, you know, like it's not a hematoma, it's not a lymph node, there's an actual vessel that is in that area. And, you know, the patient would definitely appreciate you documenting that. So now that you have imaged the deep vessels, then you're going to go into the GSV and the SSV. So that's my protocol. Personally, I like to do the DVTs first, do all those images first, and then go into GSV, SSV. I know some people that go into the pop and then they leave the calf until the end. But, you know, again, it's completely up to you. So you're going to start up in the Saphenofemoral junction again. And then you're going to start doing the Valsalva maneuvers and augmentations throughout, okay? So here you're going to have the GSV prox, mid, distal. You can evaluate it in the thigh, and then you can go through the calf and the ankle as well. So you can do prox thigh, mid thigh, distal thigh, then prox calf, mid calf, distal calf, and then at the ankle level. And then you can go behind the knee and evaluate the SSV. So besides the usual compression, collar Doppler, pulse wave Doppler, you also want to measure the diameter of the vessel and see how thick that GSV is. So that's going to determine, so for insurance purposes, they're going to look at how big the vessel is and how bad the insufficiency is. And then based on that, then they'll determine if that's something that will be covered by insurance or not. So usually if the diameter of the GSV is greater than 5 millimeters, then that's a bad, a positive GSV insufficiency. So remember that throughout your study, you want to make sure that you're looking for those perforator veins, whether it's part of your protocol or not, then just make sure that you are able to document that there's an incompetent perforator in your study. And like Alain mentioned, that's a vein that communicates the superficial system to the deep system, okay? And you would measure this once as well. In a sagittal, let me show you guys. So let's say you have the GSV here, and then you have a deep vessel here. You're gonna have the perforator going through here. So you're gonna measure from here to here. So that's what you would document if the perforator is dilated, okay? All right, so Valsalva is usually more efficient for anything above the knee. So if you're evaluating the GSV above the thigh, then in the thigh area, then you're gonna use Valsalva. Anything below the knee, then you're gonna do augmentations. Okay, it's just more efficient as it is, you know, more proximal. So let me just delete this real quick. Okay, so I know some facilities are really lucky and they have this augmentation device. If you have that, it's super convenient because you don't have to go back and forth and do your augmentations. So it's very ergonomic for us. So if you definitely have that equipment, then make use of it. It will definitely make your life easier when you're doing the distal augmentations, okay? And if you don't know how to do a Valsalva maneuver, is you have your patient either tighten up their abdomen, take a deep breath in, or you can, if they don't know how to do it, then just press on their abdomen. You're gonna press down. As you're pressing down, you're not supposed to have anything in that baseline, nothing at all. then when you let go, it's supposed to go back to normal. So if you have something in there, that's reflux. So I'll show you guys an image later on, okay? Another technique that you should take advantage of when it's a really bad venous insufficiency case, you're going to have a lot of varicosities. A lot of those, like here, you have a lot of varicosities and a lot of tributaries and all that. So it's hard to sometimes differentiate the GSV from other vessels. So like Elaine mentioned and showed you guys earlier, the GSV runs within that fascial sheath. So if you have that hyperechoic layer at the top and then another hyperechoic layer at the bottom, and you have that vessel there, then that's the GSV. Anything that it's within the subcutaneous fascia, that's either another branch, or it's what you call it, just a varicose vein or anything else, but it's not the GSV. So make sure that you're measuring the right thing when doing this test, when doing this part of the test, okay? And even if when you're doing, if they want to use the GSV for anything related to the heart, for a bypass, and you're doing a vein mapping, and the patient has this kind of issues, you know, you want to make sure that you're measuring the right vessel, not giving them some false information, and they think that the vessel is good for usage when it really isn't, okay? So make sure that you're keeping that in mind. Some of the settings that I'd really like to use when I'm doing venous insufficiency are the sweep speed and the wall filter. So the sweep speed, if you have a really bad venous insufficiency that lasts more than 3, 4, 5 seconds, you want to make sure that you're getting that measurement in its entirety. So if you see that you can't fit that measurement within your baseline, then you can decrease the sweep speed. It goes down all the way to 1. So in some of my images, I'm able to go all the way up to like 10 seconds, something really crazy like that. So just take advantage of it. That way you can have a true measurement. And then the wall filter, make sure that you don't have it really too high, because when you have it really high, you're gonna have this gap in between the baseline and the actual waveform. It's gonna be a space. So you're gonna be eliminating a lot of information that you would need to diagnose a venous insufficiency. You could actually miss some venous insufficiency if you have it too high up, because it's creating that space in between the baseline and the waveform. Some facilities calculate venous insufficiency in moderate, mild, severe. Others use a grading scale, so grade 1, grade 2, grade 3, grade 4. Every facility is different, so just make sure that you're going by whatever criteria they're following. Here you have this baseline if you don't have something in your facility. Grade 1 is 0.5 to 1 second. Grade 2 is 2.2 to 3 seconds. Grade 3 is 3 to 6 seconds. And then grade 4 is more than 6 seconds, okay? Like I said, if incompetent, the GSV or the SSV, they should be measuring 5 millimeters or more. So take that into consideration when you're doing your measurements of the anterior posterior diameter. And then for the perforators, it should be 3.5 millimeters or more. And then when you do the reflux with the pulse wave and do your augmentation, if you're able to get reflux, then it should be 350 milliseconds, okay? So in this image, you're gonna see what a normal vein that doesn't have reflux looks like, and then this is the abnormal. You have your baseline here. You have your baseline here. This is pretty much at rest when they're breathing normally. Then this is a normal response when they like took a deep breath in or that gesture. So you don't measure that. This is the Valsalva. So you saw that this is that movement that they made. And then from here to here, nothing was created. So then this is when the person released or relaxed. Then here, this is the abnormal, your baseline. You see this waveform here. They did their Valsalva maneuver, and then all of this came back. And it was almost 12 seconds here. So that's why you want to make sure that your sweep speed is as slow as possible when you have a positive case. That way you're able to fully take advantage of that feature and measure the true severity of the case. Then when they stopped, it released here. So that's a really bad venous insufficiency case. If we look back to our criteria, a grade 4 is something greater than 6 seconds, and that one was double the 6 seconds. So yeah, that was pretty much the end of my slides. I hope you guys find it helpful. We sent this PowerPoint to you guys in your email, so if you have ever any questions or anything, you can refer back to it at any time. We're gonna leave this presentation up on YouTube for a few days, so take advantage of it if you want to refer back to it. And if you ever have any questions, you're more than free to reach out to me or Align, and we would be happy to help you. Okay.
All right, cool. Very cool as always. All right, so let me show you this right here.
All right, so I'm gonna, do you want me to stop sharing my?
Yeah.
All right, cool.
I'm just gonna share mine here. Okay, so before going into the questions and answers section, let me just show you this right here. Okay, so we're gonna have a webinar, which is gonna be on October 23rd, 24th, and 25th. It's gonna be about vascular. It's gonna be the entire day. We're gonna talk about like so many things in here. It's gonna be awesome. So it's gonna be like 3 very intense days in here. So let me just show you real quick the agenda. So we're gonna have day 1. So we're gonna cover Doppler, we're gonna cover hemodynamics, and we're gonna cover quality assurance. We're gonna talk about all of this true positive, false positive, and all this creative things in here. So day number 2, so we're gonna go over cerebrovascular, we're gonna cover transcranial Doppler, all of this about the carotid system. It's gonna be very, very, very fun. And then also we're gonna cover arterial system, peripheral arterial system on day 2. Day 3, we're gonna cover more arterial system and other non-invasive studies in here. And also we're gonna cover abdominal vascular as well, and we're going to cover venous system as well, as you can see it in here. Okay, here, so we have abdominal vascular, here we have venous system in here. So it's going to be very intense, it's going to be very fun, so we're going to have sections for questions and answers, so it's going to help you. So this webinar is going to be basically for those people or students or colleagues, sonographers, physicians, that they want to learn a little bit more about vascular, or if you're getting ready for your RVT or RVS exam, so you can use this one. It's going to help you a lot. And it's going to give you 18 CME credits approved by the SDMS that go straight to your ARDMS bank. And also with this, you guys are going to have 6 months access to a lot of information. So that's the self-study program. So you're going to have free access to this one. It's included in your webinar. And here you have, lectures about Doppler, hemodynamics. You have PowerPoints. You have access to quizzes and exams. So you're going to have a lot of information in here. So Let me just go back. So hopefully we want to see you there and have fun and make this weekend, a little bit better. If you like vascular, because, having a weekend for, studying sometimes is painful. All right. You can go to the beach and somewhere, but we're going to be like doing this here. Okay. Coming back to the presentation. No, not presentation. Now it's time for questions and answers. All right. So let's do it. So if you guys have any questions, you can open your microphone. You can ask, say your name. If you're like sometimes a little bit shy, it happens. You can use the chat section as well, right here. So any questions you have? There's always a question. Always, always. Don't be afraid. If we have the answer, we tell you. If we don't, all right, well, I'll tell you later. So also we are thinking, and I'll keep you guys posted about one session for questions and answers for the vascular exam. We're thinking and doing that one in the next 3 weeks. So we're gonna keep you posted. So it's gonna be like one-on-one before, between you and me and Darian. So it's gonna be fun as well. So that will be also free. All right. So as we're going to keep you posted as well for that one. So think about any questions you have. I'm going to give you time for that one.
Can we go through the presentation again?
For this one?
I'm just kidding. I came in late.
I was like, all over on Friday. We can do it. We can do it. A little bit of polka or something, and then we'll do it. All right. So, well, if you guys don't have any questions or anything, thank you for making it. I hope you had a lot of fun with this. You learn. We always learn something.
Okay, I do have a question.
Yes.
From experience. Okay, so when I'm scanning the PTVs and the perineals, and I guess those peripheral veins is what I'm seeing that are very like that connect, that go, so they run from the knee to the ankle, and then the ones that run from the posterior to anterior aspect. I thought those were before I started studying vascular, I thought they were like what is it called? Like different, like collateral vessels,
yeah,
but they're not.
They are not. They are not. I think the best way to do this, I don't know, Darian can explain a little bit more about this maybe, but I look for the deep fascia all the time, all right, which is going to be bright and echogenic. So anything like below that deep fascia is just going to be, it's going to belong to the deep system. Whatever is just above that deep fascia is just going to belong to the superficial system. That's going to help you. It looks like a line, very bright.
Do we have a picture of it in our slides?
Let me see if I can find one in the internet.
So yeah, if you see a branch and you're not sure where it's coming from, you can always just follow it for a sec and see if it's connecting to the GSV. Okay. So if you see that when I did the drawing, you would see the GSV and then a deep vein kind of in sag, and then you would have this perforator like this.
Yeah.
Right. So if you see that you are able to connect.
But I usually see them in the calf area. Wait, the
GSV goes all the way down to the ankle. So it's the whole leg. Yeah, it starts up in the thigh and then goes down all the way to the ankle. Yeah. So yeah, if you're able to see this little branch, like it's connecting to the GSV, then that would be a perforator.
That'll be a perforator, yeah.
And then the ones, the channels that we see like within the edema, like the subcutaneous fat, those are called varicose veins, or those are just, extra veins because of their edema?
Sometimes when the patient has edema, there is all of this, we call this growth factors. And those growth factors, they make little vessels in there. to grow. It could be like little arterial branches or also little vein branches as well.
Hmm.
Sometimes they belong to the superficial system. Sometimes they're just right in there, below the skin. So as Darian said before, you have to look for the connection between all of this with the main great saphenous vein or the main superficial venous system. So that's what I think is the best way. By looking for the
Okay.
connection all the time, follow the vein all the time.
Okay.
There's another question in here, Darian, maybe you can answer for this one. It says, are we supposed to check all the perforators? When I used to work in this, I checked only the perforators, the cocket perforators close to the ankle, but maybe in other clinics, you just want to check everything. So I don't know. What do you think?
Yeah, it varies. It varies from clinic to clinic. Some are more extensive than others. The most important thing about the perforators is that if you see, well, in the general clinics, if you see anything that's big, then you want to measure it and then document it. So whenever it is, it has reflux. So whenever it's not whenever it's incompetent, then you want to document it. So for when it comes to a vascular lab, like Align mentioned, then they might go out of their way and look at every single perforator. If it's not a vascular lab like that, then they would probably just want to document those incompetent perforators, not even the competent ones. But yeah, you just want to make sure that whenever you do see a little branch, if it looks dilated and you see that it's a connection, you see that it's coming off from, the PTVs and then it's going up to the GSV, then that would be a perforator vein. And then just go ahead and measure it and see if it's too big and if it has some reflux in it.
Okay, so we have another question here that says, do you have a sonographic image for a perforator vein? I think we can find one in the internet. Let me go here. Okay. So we have to see a connection between the superficial system and the deep one. I think like this one is a nice one. All right, here. So as Darian said before, we have to measure it. We have to check if there is reflux in the perforator here. Okay, there's another one in here. This is a cool picture. That's what Darian showed you before. We have the superficial system here. We have the dip system here, and that's the connection. So right here. So that's a nice picture in here.
I used to call that collateral veins.
Oh, those are perforators, and yeah, I know. We learn a lot with this.
It's okay. We do better when we know better.
We still have to learn a lot, and we learn from the students as well. So
yeah, definitely.
We're not perfect. So,
that's the thing about ultrasound. You're always learning.
You're always learning. That's the point, and you learn new stuff. Like, this criteria that we're using right now, more than 5 seconds. It wasn't like that before. Before it was like 3 seconds. So it's changing all the time. It's just changing all the time. Yeah. So here we have another question.
Yeah. Which is why you always want to, stay up to date, especially with vascular. There's always new things coming out, new procedures coming out, new criterias. So whenever you are doing a protocol for venous insufficiency or fistulas or anything, just make sure that you're following the protocol that the vascular surgeon wants. That way everyone is on the same boat and everyone's happy and everyone gets the patient gets the treatment that they actually need for that.
And those are politics, so we have to follow those politics all the time, right? So okay, so there's another question in here. It says, is there a communication between the posterior accessory vein and the vein of Giacomini? Well, in real life, no. The posterior accessories just go from one point of the great saphenous, distal to proximal, and then the Giacominis just go from the small saphenous vein to the great saphenous vein, but more proximally. So there's no connection in there. So like the picture that I showed before. So, okay, so it says here, any tips on optimizing venous Doppler waveforms? Like Darian said before, I guess like, sensitivity is important. Remember physics. If you reduce what I do, and it helps me a lot, is, I reduce my pulse repetition frequency, which is basically the scale, looking for more sensitivity. I increase the gain, and I increase the packet size as well. Remember, if you increase the packet size, it will give you more sensitivity to the slow flow, all right? It will help you a lot. And also think about your pressure. When you apply pressure, those veins are very sensible. If you use pressure too much, you're just gonna obliterate it, and then you're not gonna see the flow. So that's important to know. Okay. So let's see if I have another question for here. It says, hi from Puerto Rico. Any chance there is a Spanish webinar? Estamos pensando en eso. Sí, vamos a hacer un webinar en español. Vamos a hacerlo. ¿Cómo que no? Quizás en no sé, Darian, las próximas 4 semanas. No sé, vamos a ver.
Sí, vamos a hacerlo.
We can do one Spanish webinar as well. Yeah. I don't know. We can do a German one as well. I don't know. We can learn something new.
Yeah, I'm a little bit off on my German.
Okay, right? I don't know. So, so we have many questions in here, but well, we would love to answer.
I think Cindy has a question whenever.
Cindy, I have a question, but I will wait for everyone else's question before turning my mic on. Yeah.
So go ahead and ask whenever you're ready. Let me see. She's still on. Okay. Bueno, there's. I think we have another question too. It's about SSV. Most of the time I scan SSV, it does not go into pop vein. Should I call this patient? So if it doesn't go into the pop vein, should you call it the SSV or not? That's a question, I think.
Okay, scan the SSV. It does not go into the popliteal vein. Well, in a normal anatomy, it should go into the popliteal vein. But patients, they have anatomic variants all the time. Or let me tell you something. Sometimes these patients, they had a previous ablation or something. They don't know. Sometimes we don't know, and that's why you don't see it. But that's a good question. I may check if there is any anatomic variant where the small saphenous vein doesn't go into the popliteal vein. I have to check. But it should go in there. It should go in there. You should see it at the popliteal fossa. And right there, yeah.
Yeah. I'm not sure about the question either, but most of the patients, the SSV and the gastrocs would dump into there as well. So we would have to get back to you. You can join the Q&A that we're going to be hosting in a few weeks.
Yeah. So in 3 weeks, we're going to do the questions and answers webinar.
At least 40% of SSV does not connect with pop vein.
Yeah, 40%.
Leslie. Thank you, Leslie.
That's good to know. Good.
Hello?
Perfect.
Hello?
Yeah. So like I said before.
Yeah, go ahead.
Someone's
sorry. Speaking.
It's Cindy.
Oh, okay. Hey.
Okay. So
That's Cindy, my student.
So my question is, I was taught 2 different ways to do refluxes, and I just want to know which way is the correct way, because we started doing ablations at the hospital that I'm working at, and I feel like I don't know which way is the correct way to do reflux. So The first way I was taught was to hold proximal to the GSV, and then if something showed above the baseline, that was the reflux, and then release. And then at the hospital I'm working at now, they taught me that you have to hold distal to the GSV, and when you're holding it, that's the reflux, and then release is release. So I don't know which way is the correct way. Does that make sense?
Can you say it again a little bit, like slower?
Okay, sorry.
Like you start proximally, right?
Okay, yeah. The first time I learned it,
you're doing the augmentations in different areas. So instead of distally, you're doing it proximally.
Okay, the first time I learned it, I was taught to do just straight prox, like proximal of the GSV. So prox GSV, when you hold it, that was the reflux, and then you measure that and then release. And then when I started working at this other hospital, they told me that you have to hold distal, and when you're holding distal, whatever popped up when you're while holding was not reflux, and then when you released it after the release was the reflux.
So when you're doing augmentations, the reflux is going to be after the augmentation. When
It's
you're doing the Valsalva, yeah.
It's what they're teaching me right now at the hospital I'm working at.
Yeah, right. So you're going to have the waveform, your normal baseline, then you're going to do your augmentation, and then that's going to, you're going to release, and the reflux is going to come out.
Okay, so after the release is the reflux time?
Yeah, but it has to be in an opposite direction. That's good to know. Like you have the normal below the baseline, and then the reflux is just going to be above the baseline.
Above the baseline.
Yeah.
So is there a difference from doing prox hold and distal hold? For when doing reflux?
So where are you holding exactly? So are you talking about the augmentations?
All right, so the one I'm doing, well, since they told me I have to do it like this at the hospital, is doing distal from GSV. So say we're doing GSV mid, hold distal from it.
Yeah.
And then the moment you release it, that's the reflux.
Oh, you're fine.
Okay, and then,
Okay, so.
Yeah. So usually for proximal, I mean, people do it whatever makes you feel more comfortable. You can do Valsalva maneuver for anything prox. And you can just like hold the patient's abdomen, hold it. And then and that's the difference with the augmentations on the Valsalva. The Valsalva, the reflux is going to come up when you're holding, as you're holding. You want to try to hold as much as possible until you see that release. Okay. With the augmentation, you're going to do the augmentation, let go, and then you're going to see the release above the baseline.
Okay, that makes so much
So with
more
one, you're
sense.
holding, with the other, you're not.
Okay.
Yeah.
All right, thank you so much.
You're welcome.
We're going to have this last question in here. Maybe Darian, you have the answer for this one. It says, I have a hard time finding the peroneal veins. Any tips? Like, how do you find those?
I love, that's one of my favorite shots to take, the PTVs and peroneal veins. So the way that I usually get it, and even on big patients, it's all about the angling. So you want to have the patient bend their leg, obviously, and then you're going to use the tibia. So usually what I do is I have the tibia here, right? And then I put my probe and then I angle it this way. I wish I had a machine Align does, but maybe in the future. So tibia here, I usually put my probe, so you're going to feel that, that bone there, and then I tilt it towards the medial side. And then you're going to be able to see the PTVs. Usually it's not always the case with most patients. As we know, different patients have different anatomy, but I've seen that usually when I do that angle, I'm able to get both of them at the same time. And I have an image. Let me see if I can show you guys real quick that I took it on my Instagram. And that's how I was able to take that shot. But, it varies from patient to patient. Let me show you. So yeah, usually that's the way that I do it. You have your patient bend the leg, not too much, but just, it depends on the patient. Some you have to bend it a little bit more than others, but definitely, you want to use that landmark right on the calf, get in that area instead of going backwards. So instead of going in the calf tissue, use that bone as the landmark and then go tilt inwards, so medially. I don't know. My internet's acting up, but anyways, that's usually how you want to do it. Okay, that's usually how I do it. You can find it on the Instagram, on our Instagram. The image is there.
Right.
So
Very cool.
for the webinar in October, is there live or is it recorded so we can view it at our own time?
It will be 100% live. So we're not gonna have a recording later. So it's just like live attendance with us right there. So
the last question before so how do I differentiate between PTVs and perineals? PTVs are more anterior, perineals are more posterior. Look, I'll show you here. So that's the picture. You're gonna have the PTVs up here and then perineals down here. Okay. And the same on my presentation. On my presentation, you can see the PTVs and perineals in transverse. That's a sagittal shot. So Align has a picture of it. I put a picture of it as well in transverse. So just refer back to the PowerPoint. And if you guys have any questions, you can always reach out to us for anything.
And the webinar is going to be available in YouTube, in our pages, Sonography 101. It's going to be an Ultrasound Med Academy as well, YouTube, Facebook, all these places. So we're going to have this webinar right there for limited time. So just go back in there and take a look and, check all this information one more time. All right, guys, thank you for making it. It's been a nice Friday. Have a nice weekend. It's a long one. And let's go
enjoy it.
Back to work on Tuesday. All right. So thank you for making it. Thank you.
Bye. Have a good night.
Bye,
thank you guys.
Bye. Thank you.